Hey guys, thanks a lot for joining the CE tonight. I'm going to be talking about feline neurology. First, I wanted to tell you just a little bit about myself because it's my first CE at NVS. A lot of you may know me because I'm actually a Nashville native. I went to Hillsborough High School and I grew up working for David Edwards over at Bellmead Animal Hospital. And I did the majority of my training, including a residency in neurology and neurosurgery under Billy Thomas at UT, who many of you also probably know. And that's him in the first picture there. And then the same year I finished my residency, I became board certified in neurology, like Becky said. I also hold a certificate of advanced neurosurgery training through the ACVIM. And in 2019, I started my dream job at NVS, working with Dr. House on the neurology service as the second neurologist there. Within the field of neurology, my special interests include neurosurgery and immune-mediated CNS disease. And in my free time, I really like mountain biking and spending time with the love of my life at our farm in Kentucky. That's us in the third picture. And recently, I dyed my favorite dog, Hot Pink. That's her on the end. I've got 4 dogs, but this one's my favorite, and her name is Cricket. Why feline neurology? Well, the answer is it's challenging. Many of you know the sickening feeling in your gut when you're faced with a very neurologically abnormal feline patient, and the secret is many neurologists have that same reaction. The reason for this is that feline neurology is very challenging. It's difficult to diagnose without advanced imaging and spinal fluid analysis, and even sometimes with those tests, we don't reach a definitive answer. We also know less about cats than dogs within the field of neurology, and many of the diseases that we see in cats are extremely difficult to treat and carry a poor prognosis. So for all of those reasons, I would say that feline neurology is very challenging, even to neurologists. And so that's why I wanted to talk about that today. This is just an outline for the talk. We've got 2 hours to spend on feline neurology, which is not a lot of time. But first, I'm going to talk about just how to assess your feline patient. And this is really the focus of my talk today. I think assessing the neurologically unwell cat can be extremely challenging, like I said, and even intimidating. So I'd like to spend the majority of my presentation just talking about tips and tricks for how to perform a good neuro exam on a kitty, because after all, when it comes to neuro, that's your most useful tool. And then after that, we'll talk for a little while about 2 of the common presentations that you probably see in your practice, presentations of neurologic disease, including the presenting complaints of ataxia and seizures. And for each of those presentations, I'll talk a little bit about a couple of the most common diseases that we see responsible for those clinical signs. And then at the end, we'll have time for some Q&A. Meet Lilu. This beauty belongs to one of our employees, and she's one of the superstars of NVS for obvious reasons. Lilu does not have any neurological illnesses that we know of yet, but I've got her up here because I'm going to be interposing some adorable videos and photos of Lilu throughout my presentation, mainly just for kind of a break and a little bit of comic relief because she's really cute. So let's just start by quickly reviewing the feline neuro exam. The goals of the neuro exam are to differentiate neurologic from non-neurologic disease, such as orthopedic injury and systemic illness. Many systemic conditions can masquerade as neurologic conditions on preliminary examination. Examples include things like sepsis with hypoglycemia, or aortic thromboembolism masquerading as a T3L3 lesion. The next step of the neurologic exam is lesion localization, which is everyone's favorite part. And then based on that, we can prioritize differentials and choose appropriate diagnostics. Here's a list of recommended supplies for your neuro exam. And I think by far the 2 most important things to have are 1, a quiet room that's closed and safe for your patient to wander around and to explore and to first become acclimated to the environment and really show you what he or she can do. And then number 2 is having a yoga mat or another type of non-slip surface to do your hands-on exam. Not only will that allow you to more accurately assess your patient's strength and postural reactions, but having that adequate traction will make things less psychologically challenging for the patient, as we all know. And then number 3 is, for my feline patients, I always use a towel to cover up the patients on the exam table, and then just selectively perform aspects of the exam by folding back the towel, just like you would for a regular physical exam. Here are the components of a good, thorough neurologic exam, and this is the typical order that I go through my exam in, but there are exceptions, and I'll get to that later. But what good is a neurologic exam without an understanding of neurolocalization? I love neuroanatomy and localization and could talk about that for 2 hours today, but I'm just going to go through a really quick review of broad localization regions along with some of the exam findings and clinical signs that will help you neurolocalize and sort of red flag in your mind when you see those signs. So starting with the forebrain or cerebrum, I'm going to go through this pretty quick. All seizures come from the forebrain in dogs and cats, period. So if you have a patient presenting to you with seizures, you automatically know that there's forebrain disease. You may also see lateralizing signs like circling. You can see ataxia, proprioceptive ataxia, dementia, blindness, and behavior changes. For example, my cat is no longer interacting with me the way he or she used to, or my cat is sleeping more, or my cat seems a little dull. With the cerebellar lesions, some of the most common signs you can see include cerebellar ataxia and vestibular signs. And one of the hallmarks of cerebellar disease within the context of other intracranial illness is that a pure cerebellar disease should not have an influence over mentation and behavior. With the brainstem lesion, you can see a change in the animal's mentation and overall level of awareness. And this is really important because the brainstem actually houses the major components of the ascending reticular activating system. And that's the system or network within the brain that governs level of consciousness. So the importance of this is that if you have an animal that's profoundly dull, stuporous, or even comatose, you're likely dealing with a brainstem illness. And in some cases, you don't even have to have a primary brainstem illness to account for those clinical signs. For example, I'll often see dogs and cats presenting with major structural lesions within their forebrain, such as a brain tumor. And in those patients, the profound change in mentation is secondary to brain herniation due to compression of the contents of the caudal fossa, which includes the brainstem. Additional clinical signs you could see with a brainstem lesion include weakness, and especially profound weakness, ataxia, and then of course, cranial nerve deficits, including vestibular signs. With a cervical lesion, don't get bogged down by trying to distinguish spinal cord segments C1, C5 from C6 to T2. It's really not going to influence your differentials for the most part. I just like to ask myself, is this patient normal from the neck up and abnormal from the neck down? If the answer is yes, you likely have a cervical lesion. One of the most important things to assess here are the spinal reflexes of the pelvic limbs. These should be preserved in a cervical lesion. And this is important because it can be a distinguishing factor from weakness induced by neuromuscular or peripheral disease, such as a myopathy or a polyneuropathy from a cervical lesion. With this type of problem, the patient may be normal from the neck up and weak from the neck down, but with a peripheral lesion, they will likely also have diminished tone and spinal reflexes in the pelvic limbs. And of course, there are a lot more nuanced distinguishing features, but I think that's just one of the main and important things to look at. Moving on to a T3L3 lesion, the hallmark sign is that this patient should be pretty normal from the waist up and then have varying degrees of pelvic limb proprioceptive ataxia, sometimes called spinal ataxia, weakness ranging from paraparesis to paraplegia. They can also have variable sensory perception as far as the ability to consciously perceive superficial and deep pain. And when you're dealing with a spinal lesion affecting the pelvic limbs, the most important part of your localization here depends on assessing the spinal reflexes again, because with a pure T3 to L3 lesion, your spinal reflexes should be unchanged. That is in contrast to an L4 to S3 lesion. Those are the spinal cord segments where our lower motor neurons live, the ones that contribute to our big spinal reflexes in the pelvic limbs. And so an L4 to S3 lesion can look similar to T3L3, but often with a greater degree of paresis. And sometimes you can see flaccid tail tone, and then of course the diminished spinal reflexes. Before I go through how I assess my feline patients, I just wanted to plug this review. It's from the Journal of Feline Medicine and Surgery in 2009 by Laurent Grossi. And it's a really great review. It just goes through how to do a good feline neuro exam. And it has a lot of really good, helpful tips and tricks. So I would highly recommend this for additional reading, especially if you see a lot of kitties. Again, here are the components of the neuro exam. I definitely believe that these first 4 components are the absolute most important part of assessing a feline patient. And the best part of that is that these 4 things can be assessed without even touching your patients. I believe that the hands-off exam is the most important part of evaluating a cat with neurologic illness. The obvious exception to this would be a patient that's completely obtunded, comatose, paralyzed. Obviously, you're not going to get as much on your hands-off exam. As far as assessing mentation, this is really asking what is the patient's level of consciousness. And in neurology, your options are dull, stuporous, and comatose. When I'm assessing behavior, the main question I ask myself is this patient interacting normally with his or her environment? The key here is the environmental context of the hospital. So the average cat should be pretty scared in the hospital, or at least nervous. They shouldn't be, for example, falling asleep in the middle of the exam room floor. So just keeping that hospital context in mind, I think, is really important. When assessing behavior and even mentation, it can be really inviting to call a patient abnormal if they have generally a large abnormal neurologic appearance. And what I mean by this is, don't get thrown off by profound ataxia or like multiple cranial nerve deficits. It's inviting when you see a patient that looks really neurologically abnormal to just assume like, oh, their mentation and behavior are affected because the way that we're perceiving them is that they're very, very abnormal. So consider the patient's behavior and mentation within the context of those other deficits. So for example, an acutely blind cat will likely be extremely fearful and quiet and may just sit there, but don't interpret that as dullness necessarily. This is an example of a patient with a severe cerebellovestibular ataxia, and he is displaying normal behavior. Go ahead and run all of these. So I described the ataxia cerebellovestibular because the patient has a base-wide stance. He's crouched with moderately low head carriage, and his gait is characterized by stumbling, swaying, falling, and also truncal sway. This kitty's gait, to me, is most suggestive of a bilateral cerebellar lesion rather than the type of vestibular ataxia that we might expect with a peripheral lesion or even a brainstem lesion. Those clinical signs are usually more lateralized and include a head tilt in one direction, falling in one direction, and rolling in one direction. This kitty has elements of a vestibular ataxia, but it's pretty symmetric. So in this video, you can see that he's severely ataxic, which at first glance might invite you to interpret him as being also mentally inappropriate. But if you look really closely, he's actually interacting really normally with his environment. He's sniffing the stool. He's like nervous looking and wide-eyed. He's interacting with me, the toys. He's looking for a place to hide. All of this is just really normal behavior for a cat in the hospital. So moving on to posture. Posture is key. We can get so much information out of an animal's posture, which is great because it's another part of your hands-off exam. So in this first video, what I see is severe tetraparesis and cervical flexion. And this type of tetraparesis and cervical flexion can either be caused by a high cervical lesion, so a lesion affecting the spinal cord, or diffuse lower motor neuron or neuromuscular disease, such as a neuropathy or a myopathy. In the second video, once we waited long enough, the patient started walking, and that's when his plantigrade posture becomes evident. So this indicates that the patient has neuromuscular disease, since a cervical lesion does not cause plantigrade posture. And this kitty was suffering from hypokalemic polymyopathy. His potassium was 2.8 when these videos were taken, with the low end of the reference range being about 3.5. It really blows my mind that cats can display these clinical signs with levels under 3. 3 seems pretty high to me still for them to be this affected, but that's possible. So again, just illustrating the importance of posture and being patient with your patient so that it will walk for you and show you, everything that it can do. So a little bit more on plantigrade posture. Here are your top differentials for an animal presenting with plantigrade posture. Number 1 is dysfunction of the tarsal extensor muscles, which include the gastrocnemius and the superficial digital flexor. Number 2 would be rupture of the common calcanean tendon. 3 would be fracture of the calcaneus, and then 4 is disruption of the long plantar ligament. And so of these, only 1 is neurologic. The rest are orthopedic. So investigating number 1 a little bit more, if you can rule out orthopedic disease by you taking radiographs, doing a good orthopedic exam, then you're left with just a few possibilities. There are 3 potential etiologies for a neurologic cause of plantigrade posture in a kitty. The first possibility would actually be a spinal cord lesion. So a lesion at the level of L4 to S3. Again, these segments contain fibers which contribute to the formation of the major nerves innervating the pelvic limbs, including the sciatic nerve, which gives rise to the tibial nerve, which innervates the tarsal extensors. So because of this, a cat with an L4 to S3 spinal cord lesion can present with a plantigrade posture. And this is one of the cases where it's really easy to look at the kitty and just assume that it's suffering from a neuromuscular disease because we're so used to seeing plantigrade posture more with like a diabetic polyneuropathy, et cetera, than a spinal cord lesion. If I saw a cat that had plantigrade posture and I localized it to the spinal cord, one of my top differentials would be a spinal lymphoma. The second possibility for a neurologic cause of plantigrade posture is a neuropathy. In this scenario, the tibial nerves themselves are dysfunctional, and that results in a secondary denervation of the tarsal extensors. An example of this is what I already mentioned, the diabetic polyneuropathy that I'm sure we're all familiar with. And then lastly, a primary myopathy could result in primary weakness of the tarsal extensor muscles. And an example of this is the hypokalemic polymyopathy that we just saw. As far as posture, don't forget the tail. In cats with plantigrade posture and paraparesis, I like to pay close attention to the tail because cats with an L4 to S3 myelopathy will usually have a really droopy, flaccid tail. And one tip is if you don't see any voluntary motor in that tail, you really need to assess it for the presence of deep pain. Absent deep pain perception in the tail is a negative prognostic indicator for ever returning to fecal continence. And usually cats with a deep pain negative tail, often they're presenting to you for fecal incontinence as their primary complaint. So always check the tail. Going back to the tail and neuromuscular disease, what I was saying before is one of the kind of distinguishing features often is that with L4 to S3 disease, the tail is really droopy and flaccid, but with a paraparetic and plantigrade cat that's affected by a neuromuscular disease, it will often actually be upright and really fluffy and pretty normal looking. Here's actually an example of a patient that was suffering from a diabetic polyneuropathy. He has plantigrade posture, as you can see. and he's very paraparetic, but his tail looks really good. Upright, it's fluffy. So that's just kind of a tip to pay attention to the tail. So going back to cervical flexion, we saw that in the previous cat. Here's a grand list of causes of cervical flexion in cats. And you can see that the majority of these are either neuromuscular or secondary to a metabolic disturbance. But the thing that I wanted to point out is that, again, a cervical lesion, especially a high cervical lesion, can cause this cervical flexion. And again, a patient with this type of lesion will have preserved spinal reflexes in the pelvic limbs. So when you see a patient with cervical flexion, it's really important to check the spinal reflexes. And just a pro tip, I have an English degree and I'm really into terminology. If you want to sound really smart, just say flexion. Ventriflexion and dorsiflexion aren't recognized terms. I know that people use them in conversation and even in writing, but I think it's incorrect. Like any other part of the body, there's flexion and there is extension. So in this photo, the kitty's neck is flexed. Moving on to the gait assessment, the most essential part of the hands-off exam is to provide a safe space for the kitty to acclimate to his or her environment and then explore. And this is really the only way to get an accurate assessment of your patient's behavior and gait. And it's essential to be patient. So I will often put the cat in an exam room and then shut the door and let it explore. If you need to leave the room and spy on it through the window, like I'm doing in this video, that's fine. I probably spend 10% of my job spying on my patients, hoping that they'll walk for me. I'll also do this frequently with angry kitties, just to give them some space. And the goal is really just to give them some time and space to get them comfortable enough so that they can show you what they can do. And often, I think in general practice, this will mean just asking for the patient to drop off and letting the owner go home and letting the cat hang out, for a little while in a quiet exam room to kind of chill out and then start walking around. I've seen a lot of patients that are mislabeled as non-ambulatory just because they weren't given an adequate opportunity to walk. And for a cat, this means giving them some time and space. And after the kitty has explored the environment, then it's time to interact and play. And I think it can also be really useful to encourage safe jumping. So encourage them to jump up on a vertical space like a chair or an open kennel or even an exam table. That's a really great way to assess your patient's strength and coordination. A normal cat should obviously be able to jump off the ground onto like a low open kennel. And if they stumble and fall, well, there you've just unmasked vestibular disease or paraparesis. So again, have patience. These videos kind of illustrate that importance. So in the first video, what I see is a profoundly tetraparetic cat. He's having vestibular dysfunction. He's off balance. If I had just picked him up and started working with him then, I would have missed this. So he finally gets up and then he bonks his head. And I didn't realize that he was having major visual deficits until I saw that. And so that tells me we need to pay special attention to his cranial nerve exam so that I can differentiate cortical or forebrain blindness from a problem with the optic nerves, chiasm, or tracts. But I wouldn't have seen that if we hadn't had enough time to just really sit there and stare at him. During the gait exam, after you've allowed your patient to explore the environment, then it's time to entice them to move. We'd like to unlock the power of the cat carrier in feline neurology and really try to get them to walk around. And then, like I said, encourage jumping and play. Here's just a video of a cat with a severe cerebellar ataxia. He did have a cerebellar lesion, and we're just playing with him in the exam room, trying to get him to interact. This is also a way to secretly be assessing their visual capabilities and fine motor skills, which that's governed by the cerebellum. So this cat was not very coordinated. All right, now it's time for a Lilu break. This is Lilu, the superstar of NVS. I think she doesn't even really look like a real cat. She's so cute. Moving on to the hands-on exam. Once you finish your hands-off exam, then it's time to check cranial nerves, postural reactions, spinal reflexes, and palpation. This chart is obviously, it outlines the clinical testing that's performed to assess cranial nerves, and on the left are the specific nerves that are being tested. And this video is an example of a cranial nerve exam on a very mentally inappropriate cat. For a more aware cat or a fear-aggressive cat, I'd probably be using a cotton-tipped applicator instead of hemostats to check his sensory perception. And I would also probably not be getting my fingers so close to his mouth. So kind of going back to the beginning, first we're checking menace. He does not have one. This kitty had thiamine deficiency, and it had caused him to be blind. He was having seizures. He was stuporous, had vestibular signs. And we diagnosed his thiamine deficiency on MRI, and he got better with supplementation, and he's pretty normal now. So he had a good, happy outcome. So now we're checking PLRs and then facial sensation. His is pretty good. He does not respond to noxious nasal stimuli, though, which requires a cortical or forebrain integration and response. So having a low response to noxious nasal stimulation fit with his cerebral localization, among other things. And now we're checking him for positional nystagmus. So those are the main things that I'll recheck routinely on cats. You know, obviously if a kitty is angry, I don't usually mess around with their gag reflex too much. You can't necessarily assess phonation or, you know, kitties meow sounds differently. You can't ask them to meow. So some of these things I really don't feel like you can clinically assess, but those are the main ones that I will look at routinely if I can. And then we move on to postural reactions. So in this video, at first we're checking the wheelbarrowing response, and then that's extensor postural thrust, and then hopping. And Henry, this cat, he was not doing very well at any of these. He had terrible proprioception. Checking hopping again. And then at the end, knuckling. So in my opinion, you can really learn the most about a kitty's proprioception through the hopping, the wheelbarrowing, and the extensor postural thrust test. This is the opposite of what I do with dogs. With dogs, I usually will just focus predominantly on knuckling, but I find knuckling really challenging to perform in a cat, and it also seems like the least sensitive test for subtle proprioceptive deficits in a cat. I've seen a lot of abnormal cats display the type of knuckling that I would actually expect for a normal dog. In my experience, a normal cat doesn't even allow you to perform the test. So if you see a cat that allows you to knuckle over the paw, even if it corrects it at the same speed that you would expect for a dog, I think it's still worth further investigation. And so because of this, I really focus on hopping, wheelbarrowing, extensor postural thrust. I will just knuckle a cat if they're very weak. If they're angry or scared at all, I don't even bother. And you could kind of see at the end of this video, you know, Henry is having a terrible time with most of these tests. And then at the end, we get to knuckling. Well, that one's actually pretty bad. I think his front feet were better. Yeah, so he actually writes it like pretty quickly the first time. I think that it can be misleading. And then here is an example of a cat undergoing spinal reflex testing. I've highlighted what I think are the most important reflexes to check in a cat. I will try to check thoracic limb withdrawal, pelvic limb withdrawal, and then the perineal reflex around the rectum in every single cat. On the next slide, we'll talk more about this, but the person In this video, he's holding the cat in a special way to do its spinal reflexes. And this is not how, I was trained. We held them in lateral recumbency, but there's a movement in feline neurology to actually try to hold them like this in your lap. And surprisingly, a lot of cats are really tolerant of it, like much more so than holding them in lateral. Here he's checking cutaneous trunci, and we're not really seeing that much there. I usually don't even bother with that test because it can be so inconsistent. Here's a picture of two people checking the spinal reflexes where the kitty's in dorsal recumbency. So you can either place the cat in your lap, like that video before, or just have a helper hold the patient upright with the kitty against their chest. And this really just seems less traumatizing than being restrained in lateral recumbency on an exam table. And it really allows the cat to relax enough for you to actually assess their spinal reflexes, including the patellar reflexes if you're so inclined. Obviously not every cat is going to be amenable to this, but I'll sometimes give it a whirl, especially if I'm really feeling like I need to assess the spinal reflexes in order to differentiate the lesion localization. Moving on to something else, I have basically come to accept that a thorough neurologic exam is just never going to be fear-free. And this is not to say that I don't strive for fear-free. I'm a huge proponent of the fear-free initiative. And this article up here, I was actually featured in the Virginia Tech newspaper on cat-friendly practice certification and fear-free initiative. And I put this up here because I didn't want you all to just walk away from this presentation thinking that I was some kind of monster for saying that a neuro exam can't be fear-free. But what I've basically learned is, at the end of the day, there's really only so much you can do to minimize the stress associated with a thorough neuro exam. The components of a neuro exam basically include poking them in the face, pretending like we're going to hit them in the face, holding them upside down, and banging on their legs with hammers. That being said, there are a lot of things we can do to minimize stress. And for me, I would say the way that I try to go about this is to keep in mind that the goal is to get the most information with the least amount of handling. And again, this reinforces that we need to do the hands-off exam first. And then what I recommend is prioritizing the components of your hands-on exam based on which aspects you think are going to give you the most information. And this is really key. The purpose behind performing the hands-off evaluation first is that you can sort of start creating a list in your mind of possible neurolocalizations and maybe even differentials, and then you can prioritize components of the hands-on exam to perform the components first that you think are going to give you the most information based on what you learned from your hands-off exam. For example, if you suspect vestibular disease based on your gait analysis, but you're not totally convinced because the patient maybe doesn't have a head tilt or resting nystagmus, you might want to start your hands-on exam by checking first for positional nystagmus, just straight out of the chute. Rolling your patient on its back is going to spend a lot of kitty minutes, no matter how much time you take getting to know him first. Another example would be if you're worried about spinal disease from the gait analysis, maybe don't start with the cranial nerve exam. That's really stressful. Start with the postural reactions and spinal palpation first. And this is a little counterintuitive to what we're taught, and it's the opposite of how I approach dogs. So here's an example of what I'm talking about. In the first exam, you can see that Henry has a vestibular ataxia. So one of the first things we could consider doing in our hands-off evaluation would just be to check for positional nystagmus, which he had. I'm sorry, a lot of these videos are sad. This cat got better though. It was a happy outcome. So moving on to the weird stuff. There's a bunch of weird stuff about cat neuro. So we've all heard the expression that cats are not small dogs. This is especially true when it comes to neuro. There are just some ways that a normal feline neurologic exam is going to really differ from a normal canine neurologic exam. And the main things I'm talking about are the menis response, the patellar reflex, the cutaneous trunci reflex, and then just that cats are inherently highly coordinated, a lot more so than dogs. As far as the menace response, it's been known for quite a while that the menace response can be unreliable. This is likely due to stress. That's what people think. Stress secondary from being in the hospital. And finally, in 2018, this group investigated this for the first time. They did this really interesting paper in the Journal of Feline Medicine and Surgery where they investigated the reliability of the menace response in cats. They looked at 50 cats that did not have neurologic or ophthalmic disease. And what they discovered was that actually in 100% of the cats they looked at, they were able to elicit the menace response in some way. It's just that in 40% of them, if they tried to do it the way that we are traditionally taught to, where you cover up the contralateral eye, the menace response failed. So this was interesting, and this group also identified that the most reliable way to elicit it was actually from standing behind them. And both of these are contrary to what's classically taught. So probably the best way to menace a cat is to have it in your lap, like the guy in that video several slides back, to menace it without covering the contralateral eye first and just see, do they have a positive response? If so, then you can go on to cover the eye, and check it the traditional way if you want to try and get more information. This paper was interesting because it sort of spun on its head what people previously had just accepted, which was like, oh, the menace response is unreliable in cats, don't even bother, you can't trust it. And it's kind of like, well, then why do we do it if you can't trust it? So here's a different way to do it. The next part of the cat neuro exam that's a little variable is the patellar reflex. So if your patient isn't relaxed, this can be absent. In the absence of other neurologic deficits that are localizable to a lesion that would fit with absent patellar reflexes, I think that it just means your patient is nervous or excited. So, a lot of times by the time I get to spinal reflexes in a cat, they're squunched into a little tight ball, and I can't even really find their patellar tendon. So I just don't even bother, especially if I've already identified that they're suffering from like a vestibular lesion, or something like that. And then the same goes for the cutaneous trunk eye reflex, also called the panniculus response. It's also unreliable in cats. I don't test this in my patients routinely because it just makes them mad and doesn't really give me much information. If I have a patient that is paralyzed, that would be the one exception where I test the cutaneous trunk eye reflex in order to try and nail down exactly where my lesion is. An acutely paralyzed cat, due to neurologic illness, is a pretty actually rare presentation. We see a lot more ataxia, seizures, things like that. So I just don't even typically do this. But the grand conclusion is that in patients that are fearful or angry, it's okay to just skip all three of these tests. The caveat is that you really can only skip the menace if you can prove to yourself in other ways that the cat is visual, like through cotton ball tracking or maze navigation or something like that. And then this last slide, I just always try to keep in mind, cats are so coordinated. Like, can your dog do this? Probably not. Cats have a larger cerebellum to cerebrum ratio than dogs, and the cerebellum governs fine motor activity. The point of this is that it's often a lot more difficult to elucidate mild or subtle deficits like mild paraparesis and mild ataxia in a cat. So watching them really carefully for subtle deficits and trying to get them to jump up on a counter or a table or something like that. And then also just asking the kitty's family about its mobility at home is so important. Is he still able to jump on the furniture, use stairs, access the litter box? Is he snatching birds out of the air still, or has that behavior changed? So I just try to keep in mind that they're highly coordinated, and so what I'm seeing may not be 100% representative of their true neurologic status. So this is super weird. This cat has these moments where she like short circuits. You guys are going to want to see that again. She's one of the cutest cats I've ever seen, but I'm not really sure what that's about. But I wanted to show it to everyone. Fits with the feline neurology talk. So now we're just going to talk some about a couple of common presentations that you see in general practice and on the neurology service and on the emergency service, and a few of the most common diseases that are associated with those presentations. And we'll start with ataxia, such a broad presenting complaint. So just a quick review. There are 3 forms of ataxia. This, will present as owners say, trouble walking, difficulty walking, uncoordinated, falling down, down and rear. Often the presenting complaint is really just ataxia. The 3 forms are proprioceptive ataxia, which is also referred to sometimes as spinal ataxia. It's not always spinal ataxia because an intracranial lesion can cause a proprioceptive ataxia. But anyway, then a vestibular ataxia and a cerebellar ataxia. So those are the 3 distinct forms of ataxia. The typical proprioceptive ataxia is characterized by the brain's ability to sense where the limbs are in space relative to the body. And it will often manifest as crossing over of the limbs that will slowly slide out from underneath the patient when they're standing, toe scuffing, and then my favorite, an exaggerated swing phase of the gait where the leg swings forward too far as the patient is advancing the limb. Next is vestibular ataxia. This is characterized by dysregulation of the balance system and manifests as stumbling, leaning, falling, rolling, and swaying, often with a propensity to one side. In cats, they'll often have a really crouched posture with this type of ataxia. They want to get low to the ground. And if the lesion affects the vestibular apparatus bilaterally, they'll do what we lovingly refer to as the Stevie Wonder, which is professionally described as bilateral excursions of the head and neck. But they basically swing their head and neck back and forth to either side, and that's really classic for a bilateral vestibular disease, which I think neurologists get excited when we see that because it's kind of neat. The 3rd form of ataxia is a cerebellar ataxia, and with this kind of ataxia, you may see hypermetria, which is exaggeration in the range and rate of motion. You can see truncal sway, intention tremors, and head bobbing, which is just a form of an intention tremor. And because the cerebellum provides inhibition to the vestibular system, which is tonically firing, a patient with cerebellar ataxia can also have elements of a vestibular ataxia, in which case we refer to it as a cerebellovestibular ataxia. And this is Weebles. He's a friend of mine. He also belongs to an employee of NVS, and he has his own Instagram page. He has a cerebellar lesion. We don't know what it is. It's congenital. I don't think it's cerebellar hypoplasia. I think he has something else going on, but he gets around really well. He has a great quality of life, and he has a beautiful cerebellar ataxia. This is just a nice chart for your later reference, just to help identify different types of ataxia and better neurolocalize. And then before we move on, here's another great review from the Feline Journal of Medicine and Surgery on ataxia. I'm just putting it here for your later reference. I really like reviews. Back to presenting complaints. I'm going to talk with you about 2 of the most common causes of progressive ataxia in a cat. The first disease is feline infectious peritonitis, and this would be at the top of my differential list for a cat presenting with progressive vestibular ataxia, especially if I could find clinical signs or deficits localizable to a central vestibular lesion, and especially if the cat was under 3 years old and it had a really insidious onset of clinical signs. So CNS FIP presents in the absence of cavitary effusion. It's the dry form that goes to the CNS. What happens is the FIP virus has a predilection for the ependymal lining of the ventricular system. And this includes the choroid plexuses in the brain where spinal fluid is produced, and also the spinal cord central canal. What we see are viral and immune complex deposition, and that induces vasculitis, and virus-laden macrophages accumulate within these big lesions along the ventricular system. And the combination of these changes induces high protein and high white cell concentration in the CSF. And in health, CSF should be really similar to water. It should have low cellularity and low protein. And the result of this really high protein and high white cell count is that it causes an obstructive hydrocephalus. And that's what actually causes the progressive clinical signs in patients with brain disease secondary to FIP. So the photo here from De La Junta is just a transverse section or sections of a fixed brain of an 8-month-old Siamese cat that had FIP. And the main lesion here is obstructive hydrocephalus. So these are the lateral ventricles, and they're humongous. The normal feline ventricles are teeny, teeny, tiny. So these are really big for a cat. This paper by Crawford et al. Characterized 3 distinct neurologic syndromes or manifestations of FIP. And in this paper, the majority of the cases that they saw actually had elements of vestibular ataxia. The most common syndrome is a multifocal presentation where cats will have clinical signs localizable to multiple areas of the CNS, including the vestibular system. And in these cases, we'll also typically see seizures secondary to cerebral inflammation and then compression of the cerebrum due to the obstructive hydrocephalus. The second most common presentation that this paper characterized was a pure or exclusive central vestibular disease. And then remember I said the virus has a predilection for the central canal of the spinal cord. The third and least common form of CNS FIP is just a pure meningomyelitis. And this often will present as a slowly progressive T3 to L3 myelopathy. So this is another form of a kitty could come to you with a progressive paraparesis and pelvic limb proprioceptive ataxia, and an FIP meningomyelitis might be on your list. The typical candidate for CNS FIP is a young cat from a multiple cat household. It's just like all other forms of FIP. But with that said, of course, we can see it in all ages. And like other forms of FIP, intact and purebred cats are more likely to become affected. The typical presentation is just really slowly progressive neurologic signs with or without concurrent systemic illness. In cats that do have systemic illness, you typically will just see these kind of vague signs like fever and anorexia, and you may have the classic clinical pathologic abnormalities like hyperglobulinemia, anemia, and leukocytosis. In that paper by Crawford et al. That I just referenced, 30% of those cases had normal CBC and chemistry panels. So I get really excited when I see high globulins, but I don't actually expect to see that with my patients that have FIP. So putting this in the bigger picture, the bigger context, this study from the Journal of Comparative Pathology, published in 2004, looked at 286 cats with neurologic disease, which is a huge sample size for veterinary medicine. This was all types of neurologic illness that they looked at. And what they found was really remarkable. The majority of cats suffered from infectious or inflammatory disease. So 32% of this big population of cats that had neurologic disease manifesting in the brain, spinal cord, neuromuscular system, you name it, had infectious inflammatory disease. And then of those patients, 51% had FIP. So that is extremely profound. You know, what it means is if you have a patient with CNS disease, one, there's a good chance it might be infectious. And if it is, there's about a 50% chance that it's FIP. So FIP is absolutely the most common cause of CNS inflammation in cats. So what can you do about this when you suspect encephalitis or meningoencephalitis in a cat? The major rule-outs in this area of Middle Tennessee are FIP, Cryptococcus, and toxoplasmosis. And I just recommend starting with your minimum database, like always: complete blood count, chemistry panel, T4, FIV, FELV, SNAP, thoracic radiographs, just looking for an answer. I really also like the Feline Serology panel number 2 that IDEX does. It has a Cryptococcus antigen by latex agglutination. It does FELV, FIV. It has Toxoplasma serology and a feline coronavirus antibody by IFA. And of course, the positive for feline coronavirus antibody is not a diagnosis of FIP, though a titer of greater than 1 in 3,200 is highly suggestive. But I like this titer because I'm mainly interested in trying to rule out FIP. It is possible for an infected cat to have a negative titer. That's been documented. But if my patient is negative, then I might be a little bit more optimistic that the cause of the neurologic signs isn't FIP. And in that case, I might be more hopeful that they may experience improvement with empirical therapy of prednisolone and clindamycin. So that's your empirical treatment if you suspect meningoencephalitis in a cat. The clindamycin to get the toxo, and the prednisolone to help with FIP, well, to help with any form of infectious encephalitis. But if you do get to the point where your patient's interested in referral for an MRI and CSF tap, I'd recommend waiting on the prednisolone, just provided that the patient isn't rapidly declining. But I would wait because this can affect test results in extreme cases. So how do we diagnose FIP? We all know that trying to diagnose this disease is absolutely miserable. It's typically achieved in the CNS, just like it is in other body systems. So by excluding other diseases and then compiling a clinical constellation of findings that's supportive of FIP. The classic appearance of FIP on MRI includes changes that represent the meningitis, ependymitis, choroiditis, and secondary obstructive hydrocephalus, like we already talked about. And then the classic appearance of spinal fluid will be highly prognathous and display a neutrophilic pleocytosis. And spinal fluid can also be tested for the presence of feline coronavirus by PCR, but it doesn't discriminate from the enteric form. But, if I see that in the face of the aforementioned changes on MRI and CSF, that's supportive of a diagnosis of FIP, especially if I'm gonna also test for a Cryptococcus and Toxoplasma and get negatives on those. Let's look at FIP on MRI. I think before we can really appreciate that, we just need to be reminded of what normal looks like. So on this image, we're looking at a sagittal plane image. So this is rostral, this is caudal, this is the spinal cord, here's the brain, this is the cerebellum, and this is a T2 weighted image. And on T2 weighted images, fluid is really bright. So you can see here is the ventricular system of the cat, and it's tiny. This is a normal cat. And then the CSF is flowing nicely through the mesencephalic aqueduct here, and then back through the foramen over the spinal cord. So going back to these kitties with FIP, this was taken from the same paper by Crawford et al. And in each image here, we're again looking at sagittal view of the feline brain. These are also all T2 weighted images, so fluid appears very bright. And you can see these bright areas here represent CSF in these images. So in each of these patients, there is diffuse ventriculomegaly. These ventricles are gigantic. They're way bigger than they should be. It's really diffuse and conserved throughout the ventricular system. And in every single case, it's causing brain herniation. You can see cerebellar herniation through the foramen magnum in all of these poor little kitties. And actually in image B, there's transtentorial herniation, which basically just means a piece of the brain that should be in front of the osseous tentorium, which is the bone right here, is squished up behind it. So it's two types of herniation on this image. And then here's normal again, just for comparison. It really drives home how big those ventricles are and explains why we see seizures and vestibular signs and dullness and progressive ataxia and weakness. And then these are all post-contrast images. They're T1 weighted, so fluid's going to be dark on these, but with the contrast, any areas of inflammation is going to enhance. And all the arrows are pointing at meningeal enhancement and enhancement of the choroid plexus, the ependymal lining of the ventricles. These changes are all consistent with meningitis, ependymitis, choroiditis. So this is a sagittal plane image. The arrow is pointing to meningeal enhancement here, and you can just see it really throughout the entire ventricular system. It's really bright. This is pointing at a choroid plexus. This is the caudal medulla at the level of the cerebellopontine angle. It's enhancing here. This is meningeal enhancement here. These are transverse images, by the way, and then this is a dorsal plane. So these are the eyeballs here. This is the brain, and it's just pointing at this enhancement. So this is really exciting. I mean, it's terrible. Compared to other forms of meningeal enhancement, this is one of the diseases where neurologists get excited because this is bright. This lights up like a Christmas tree. You know, sometimes we see meningeal enhancement and you have to like kind of squint to appreciate it and you don't know if it's real or not. And this is like, for sure, this is really bad. So how do we treat FIP? Everyone knows that we really can't. It's not curable. The prognosis is grave. I will sometimes, I'll actually usually see temporary improvement with anti-inflammatory glucocorticoids, but it's usually short-lived. And by that, I mean like 2 or 3 weeks. That's usually long enough for a client to wrap their mind around the whole process, though. I don't have any personal experience with any of the other medications, legal or not, that are used for treatment of FIP. And I've never seen anything published demonstrating the efficacy of other medications as far as CNS FIP. So back to our outline, we're still talking about progressive ataxia. Moving on to additional causes, in 2004, Marioni et al. Looked at the prevalence of spinal cord disease in cats and overall found that the most common etiology was inflammatory. So this is consistent with the previous study we looked at that showed that infectious inflammatory disease accounts for the majority of CNS illness in cats. And we already know that FIP is the most common cause of CNS inflammation in cats. Interestingly, in 2009, this second paper that was published in the Journal of Feline Medicine and Surgery did a similar kind of analysis, and they actually got a little bit different results. In their results, spinal cancer was actually the leading cause of spinal cord disease in cats. And in particular, what they found was that lymphoma. Lymphoma was the top cause. So let's talk a little bit about CNS lymphoma. Lymphoma is the most common tumor affecting the spinal cord in cats, and it's also the second most common brain tumor in cats, just behind the meningioma. Similar to the other forms of lymphoma, we see a bimodal age distribution, though it's been reported in cats as young as 6 months, which is horrible, and as old as 17 years. And similar to the other forms, we see a greater propensity of the younger cats being FELV positive. Lymphoma will most commonly affect the thoracolumbar spine, though any part of the spinal cord is fair game, and actually it's the #1 cause of progressive monoparesis in cats as well. And monoparesis will typically see secondary to a lesion either affecting one side of the L4 to S3 spinal cord segments, or one side of the C6 to T2 spinal cord segments, or the brachial plexus. And lymphoma actually has a big propensity to affect the brachial plexus of cats. It can look like anything on MRI, and by that I mean, most tumors have a specific location that they like to grow, whether it's extradural, intramedullary, or extramedullary, intradural. And with lymphoma, all three have been reported. But most commonly, the location that we see will at least include the epidural space. So what we typically will see is an extradural mass that is invading the dura and causing compression of the spinal cord. Interestingly, CNS lymphoma typically progresses more rapidly than other forms of CNS neoplasia, and this has been documented multiple times. And so this is one of the cancers that I'll often see in cats where, I hear owners saying, like, it can't be cancer, this just happened, it happened so fast. And, I think that's especially the case if the kitty's good at compensating, of course. So how do we diagnose CNS lymphoma? Actually, spinal lymphoma is typically multicentric, and so it's kind of like one of the big diseases where we can take advantage of tests that are less expensive than MRI to hopefully achieve a diagnosis first. And the most common extraneural locations include renal lymphoma and then bone marrow. So, moving on with an abdominal ultrasound as the next step after collecting your minimum database would definitely be very reasonable. Trying to get aspirates of anything abnormal and achieve a diagnosis through cytology is great. I'm not necessarily advocating you perform a bone marrow aspirate on the average paraparetic cat, but I think starting with an ultrasound is extremely reasonable. Lymphoma, as we said, can be diagnosed via cytology. This actually includes via CSF. It's one of the only CNS neoplasias that can exfoliate into the ventricular system. It doesn't always, but sometimes we get lucky on a CSF tap as far as diagnosing this. And, a lot of times when neurologists see tumors, especially brain tumors or really any kind of cancer on MRI, the spinal tap's not going to really give you much information, but this is kind of the one time where, or one of the major times where it's worth a shot. And then we can also do flow cytometry or PAR on CSF, but it takes a ton of CSF to do that. I've never actually been able to do that before. Let's talk about what lymphoma looks like on MRI. As we said, the appearance can be variable, but the most common presentation is an extradural mass. This is an MRI of a patient that I just recently had with spinal lymphoma. And on the first image here, we're going to be looking at a sagittal T2 weighted image. So this is the back of the brain, and then this is the spinal cord here. And this kind of bright heterogeneous blob, this is the culprit. So we're going to pay special attention to that. Here's the trachea, just for reference. This big black thing is a microchip artifact. I know it looks really weird, but that's what that is. And then this is a corresponding transverse image that's going to go in slices through the sagittal plane image, and the spinal cord is here. And this is also a T2 weighted image. So what we're expecting to see is this kind of bright outline of CSF and fat around the spinal cord. So there is the culprit. I'll play it again. In this sequence, you can see that there's a large compressive lesion coming in from the left side. So this is all cell tumor here, and it looks like it's associated with this nerve root and this nerve. It's growing up, and it's putting pressure on the spinal cord. It's probably also invading the spinal cord, it looks like there. So differentials for this on an MRI, number 1 in a cat would be lymphoma. Number 2 in a cat would be lymphoma. The other differential would be something like a peripheral nerve sheath tumor. And if this were a dog, that would be our top guess for what that was. How do we treat CNS lymphoma? Not very well. The majority of them suffer from multicentric disease. Because of that, there's really little role for radiation and surgery. So we're pretty much stuck with chemotherapy, and many agents have been tried. The mainstay is prednisolone with any other combination of chemotherapeutic protocols that are listed on this slide. But unfortunately, the long-term prognosis is poor. And while many patients will respond temporarily to the medication, the disease is usually rapidly progressive. And especially if they're presenting with CNS signs, it's likely that they have, a large space occupying mass within their vertebral canal, and there's just limited space there. There's really only so much that chemo can do. So it always results in humane euthanasia or death. So the next common presentation we're going to talk about is seizures, but first, a Lilu break. I thought this was so cute, and we needed something happy after talking about lymphoma. Moving on to seizures. The most common cause of seizures in cats is structural epilepsy. And that just means a structural lesion in the brain that's resulting in the clinical sign of seizures. Structural epilepsy basically just means it's not idiopathic epilepsy. Examples of structural epilepsy include things like hydrocephalus, abscess, cuterebra, stroke, but by far the 2 most common causes of structural epilepsy in cats are infectious encephalitis, with FIP being the most common. We're seeing a theme here, and cancer. There are various papers that have looked at predictors of structural epilepsy, and some risk factors do include cats who present with seizures after 7 years of age. Status epilepticus is a big one, especially if the first seizure is status epilepticus. That's a big predictor in cats. And then having an abnormal interictal exam, that makes sense, right? If they're neurologically abnormal between seizures, is probably not idiopathic epilepsy. And then this one is super interesting. It's been written and documented that cats who vocalize during seizures actually are more likely to be suffering from structural epilepsy than idiopathic epilepsy. And I'm not sure why, but I think that's really fascinating. So all of these variables are just typically more associated with structural epilepsy. This paper here from the Journal of Feline Medicine and Surgery from 2006 described clinical signs and tumor types in 61 cats with brain tumors. And they found that actually in only 30% of cats with brain tumors were they having seizures. So seizures are not necessarily, the top cause of a brain tumor, but if you have a cat that's having seizures, they may have a brain tumor. The meningioma is the most common brain tumor in cats and dogs for that matter. It's a very slow-growing, typically benign neoplasm. Interestingly, 50% of cats with meningiomas are asymptomatic. And this data obviously comes from studies looking at just necropsies of large populations of cats, like with and without neurologic illness. I actually don't know what the incidence of asymptomatic humans with meningiomas is, but I would not be surprised, I guess, if it was similar to this. Meningiomas have actually a lower incidence of seizures than all of the other brain tumors combined. So you remember from that last slide that about 30% of cats with brain tumors will have seizures. In cats with meningiomas, only 20% of them will suffer from seizures. The actual most common clinical signs are behavior changes, Excessive sleepiness is one of the big ones. Because this type of tumor is more often seen in older cats, most owners will just misinterpret these changes as attributable to aging and not suspect a problem until the tumor has gotten quite large. When you see a cat suffering from seizures, it's really important to look for the presence of lateralizing signs, and do this, in between seizures, not in their postictal phase. I've seen plenty of cats with symmetric lesions or idiopathic epilepsy show lateralized clinical signs in the postictal period. But if in their interictal period, they're circling or blind on one side or really weak on one side, that's going to be highly suggestive of a focal structural lesion. So in this video, this patient is just compulsively circling to the right, and this is suggestive of a right-sided forebrain lesion. It's important not to mistake this for vestibular disease. This patient does not have a head tilt. It does not have any stumbling, falling, rolling. It's just compulsively circling to the right, and that's really classic for forebrain disease. Another interesting clinical feature possible with a feline meningioma is the phenomenon of calvarial hyperostosis. So what can happen is the adjacent skull, adjacent to the tumor, will become hyperostotic in reaction to this tumor. And then there can also be a secondary pressure necrosis. And in some cases, it's so severe that you can apparently see it on radiographs. I've never appreciated this or seen this in real life, but I thought it was really interesting that this paper could document it. You could see it on RADS. This is not something that we will, as typically, see with dogs. This calvarial hyperostosis is definitely a cat thing. So in these pictures, what we're looking at, here's a radiograph of a cat's skull, and then here's a corresponding CT scan. And I think in the CT you can really see it the best, because you can see the skull is perfect, and then oops, it's all like punched out and lytic. This is the pressure necrosis, and then it's sort of popping out here where it's hyperostotic. And on the corresponding MRI images, you can actually see that, oops, the tumor is like growing out of the skull. So this is the corresponding radiograph where you can kind of see it. And I mean, honestly, I think if I saw these radiographs in practice, I may not even notice that. I think it's a really subtle change, and skull radiographs are really difficult to interpret anyway. We don't take them that frequently, and patients are never like perfectly straight like we need them to be. So I don't know that it's worth radiographing a cat's head if it's having seizures, but if you palpate an abnormality, it's not going to hurt to take a picture, because this is really profound, and again, not something that we see in dogs. This is just another MRI image, but it's a post-contrast image, and so you can see this like really nice contrast enhancement here. It's very beautiful. For a meningioma, if you don't get your answer on your skull radiograph, then MRI is required for diagnosis. And I'll play this several times because it's pretty striking. This MRI is just classic for feline meningioma. This tumor is especially large, and on this image, we're going to be looking from a sagittal plane, and it's a T2 weighted image again, so fluid is bright, fat is bright, soft tissue is variable. For reference, this is the eyeball. The vitreous is all bright. It looks really crazy, but that'll just be kind of your reference point as we're scrolling through. We'll go pretty slowly. So what you see in this is the presence of a very large extraaxial mass within the left cerebrum. And the mass is just causing profound displacement of the brain, the adjacent tissues, and that's resulting in multiple areas of herniation. And this was a 10-year-old Siamese cat that I saw, I think, last week, that was presenting for ataxia and weakness, but he was still walking, he was eating, he was interacting with his owner, he was using the litter box. On his neuro exam, he had really severe vestibular signs, and he had very lateralizing signs that suggested a left forebrain lesion. And I actually thought he was going to have FIP because he was a Siamese. He had this very large tumor. So I'll just play it one more time because I think it's just quite striking. So this is pretty much on midline. The parenchyma is shifted around so much, it's just really hard to see. I can't even see the interthalamic adhesion really clearly, but obviously this is the abnormal part. That is the tumor. It is so big. It's squishing this poor little brain. There is ventriculomegaly, probably because the CSF was being obstructed here due to the compression. And then unfortunately, the cerebellum is beyond repair. It's completely herniating through the foramen magnum. And then this bright stuff in the cervical spine is probably just edema from the compression. We saw the tumor, and that's something you can take out actually surgically, but we can't put this back inside the skull. Brain herniation isn't something that is gonna fix itself. So this cat had a poor prognosis because of that. This is the same patient. I just wanted to show the images from a different view. These are transverse images. So here are the eyeballs and the sinuses, and we're just going to see slices going backwards. And this is a T1 weighted image, so fluid is dark, but it's post-contrast. And so the tumor is going to be really bright. And this, you can see part of the tumor here is affecting meninges. This is what's called a dural tail, and we see it really commonly with meningiomas. And again, one of the features here is that it's an extraaxial mass, so it's growing from the outside into the brain as opposed to a mass from the inside of the brain growing out. So the top differential here, this is a meningioma until proven otherwise. And you can really see on this image how extensive it is, both rostrally and caudally, and even has some association with the falx cerebri and crosses the falx at one point. It's crawling everywhere. And then this is the final image I'll show from this case. This is a dorsal plane, same T1 post-contrast, but you can just really appreciate how big it is. I mean, it's literally taking up a fourth of the space allocated for the brain in this cat. And he was still like walking around and being sweet with his owner. He probably had a terrible headache. It's just amazing how they can compensate for this kind of thing. We would never see a human coming in with a tumor this large that was as functional. So how do we treat feline meningiomas? With the advent and availability of stereotactic radiation, surgical excision of brain tumors is being performed less and less these days. The feline meningioma is actually the big exception here, and it's the place where brain surgery still really shines. This retrospective by Cameron et al., published in the Journal of Veterinary Surgery in 2015, looked at 121 cats undergoing surgical excision of intracranial meningiomas, and they found a low perioperative mortality of 6%. And they defined that perioperative period in this paper as about a month post-op. They also found that the median survival time with a single excision was 37 months. And this is really tremendous when we're talking about brain tumors. And this is what I quote my owners when we talk about surgery. But, I know that there's a big selection bias here. This paper is a retrospective, and only a fool is going to recommend surgical excision for a patient with a humongous tumor whose brain is herniated in multiple locations. It's unlikely that that patient would do well with the procedure. So I think there really is a selection bias here. But for cats that look like they would be good candidates for surgery, that is a really viable option. They can get 2 to 3 years of good quality time before the tumor grows back, and then you can take it out again, and they will get 2 to 3 years again. That's been reported, so it's pretty amazing. For reference, the median survival time for dogs undergoing just a surgical excision for an intracranial meningioma is only about 9 to 12 months. So it's a huge difference. If you add radiation to that, you might get 1.5 to 2 years. That's a really big difference. And it's due to a difference in the histopathology that accounts for the tumor regrowth and the rate of growth, and then also the degree of inflammation and edema that's associated with the tumors in dogs. So if you're not going to do that, what can you do? Palliative care consists of prednisolone and, if you need them, anti-epileptic medications. There's actually very little published data on survival time with palliative care for this tumor in cats. In dogs, we have a lot of information. The average time with steroids alone is about 6 months. Anecdotally, I would say that cats don't usually do this well. They are sometimes more neurologically affected by dogs than dogs at the time of diagnosis. And I attribute this to how good at cats are hiding their disease until they just really can't anymore. But I think maybe one day we'll have some good data on how long we would expect a cat to survive with prednisolone alone. In my experience, not as long as a dog, which again is about an average of 6 months. Moving on to additional causes of seizures. Here's a question I get sometimes, and I already gave it away, but do cats get idiopathic epilepsy? Yes, they do. We just don't typically think of that just first and foremost as a cause of seizures in cats, I think because we see so much infectious disease and cancer and things like that. But idiopathic epilepsy does happen. It's just not nearly as common as structural epilepsy. My guess is that it's underreported, but that's just a guess. It's estimated to account for between 30 and 40% of feline epilepsy. I've seen some papers that say up to 60%, but the larger studies are more like 30 to 40%. Genetics are rarely investigated. So in humans and in a few breeds of dogs, we've identified really clear genetic components for what's causing the seizures, and we call it genetic epilepsy and not idiopathic epilepsy. And this is not really the case yet for cats. There are a few distinct forms of genetic epilepsy that have been identified, but that's mainly within specific colonies of cats that are like being studied by neurologists and comparative human neurologists, and it's just very rare. The age of onset of idiopathic epilepsy in cats is variable. So, the cutoff with dogs is about 6 years. If I have a patient that comes in that's older than 6 years that's having seizures, I'm going to be way more concerned about a structural lesion. And that's the same in cats, but it doesn't rule it out. We definitely see a larger range of age as far as the time of presentation for idiopathic epilepsy in cats. It's also been demonstrated that very young cats, like less than a year of age, are also way more likely to have structural epilepsy than idiopathic epilepsy. So that kind of sweet spot is between 1 and 6 years of age, which is similar to dogs, but I really think that they have more wiggle room. So I don't get as worried and discouraged if I have a cat that's coming in that's 10 years old, that's having seizures for the first time, if its neurologic exam is normal. So what can you do about this? Here's a nice chart on anti-epileptic drugs that are available for use in cats. And I'm not going to go into a ton of detail on this because this is not a talk on anti-epileptic drugs. But I will say that my personal standard first choice for cats with seizures is phenobarbital. I pick that because they tend to tolerate it pretty well and have a lot fewer side effects than dogs. And it's really good at controlling their seizures. So the exception for this as a first line of defense would be a cat with pre-existing liver disease or a severely obtunded cat who I think is having seizures because it might have a structural lesion like a brain tumor. In those cases, I would be a lot more likely to recommend levetiracetam, which we call Keppra, and then zonisamide next if the 3-time-a-day dosing for Keppra wasn't an option. And that's really the only downside that I see in Keppra with cats is, you probably should use the regular formulation. And if you do that, you really need to do the 3-time-a-day dosing. I've had clients tell me, like, we're only doing twice a day, and I've told them they may as well just be flushing it down the toilet. I think that if you can't do 3 times a day, you just need to do something totally different. The caveat to this is, in the past few years, there was a pharmacokinetic study published looking at the use of extended release Keppra in cats. And what they demonstrated is that if you give a cat a single 500 milligram extended release Keppra once a day, they will maintain therapeutic serum levels for about 22 hours of the day. And this is like the average size cat. What this means is that it's possible to get by with just giving your cat, 1 extended release Keppra a day. I always laugh when I think about this, because if you've ever seen the size of those tablets, you will know what I'm talking about. I cannot imagine getting one of those in my cats. So I think that this is not realistic. I've never had a client take me up on it, but it's out there. So it is a possibility. And then the other medications on this chart I use less frequently or not at all. So imipitoin is not available in this country. Pregabalin, also known as Lyrica, and gabapentin are really not good maintenance AEDs. I reserve them for neuropathic pain. And then there's another medication that's not listed here. That's topiramate. I don't use that in cats personally, but I have plenty of colleagues that do. The downside is that there's just very little data to support its use in cats or dogs, really. And so it's reserved as an adjunctive therapy for drug-resistant epileptics that, are not well controlled on the first lines of defense, like Keppra, Pheno, and zonisamide, or can't take them for some reason. And then obviously the big one that's not on this chart is potassium bromide, because while it works great for seizure control, it can kill cats. In 2018, this very, very nice meta-analysis came out looking at all the data on the safety and efficacy of anti-epileptic drugs for cats that we have. This guy did one on dogs too. It was very comprehensive and very thorough, and the results were absolutely dismal. We collectively have a really sad volume of quality data to support the safety or the efficacy of most anti-epileptic drugs in cats. So this is an area where we really have a lot of work to do in order to help serve these patients better, I think. Remission from idiopathic epilepsy is possible. The data is all over the place, but largely suggests that remission and survival in cats with idiopathic epilepsy may actually be better and longer than dogs. It's reported that 50 to 80% of cats will have good seizure control taking 1 anti-epileptic medication. And good control in this context is defined as having less than 6 seizures per year. In 2 studies, about 50% of cats with idiopathic epilepsy were seizure-free for over a year when taking phenobarbital. My friend phenobarbital, it's my first choice in cats again. However, those cats that remitted, the remission was not spontaneous. In those studies, if the medication was withdrawn, the seizures would often relapse. Actually, anecdotally, it's more difficult to achieve the seizure control a second time once an animal has relapsed. It's also written that the risk of death is 10 times higher in a cat that does not achieve a remission or acceptable seizure control. And this is a reflection of euthanasia, not spontaneous death. So if you have a patient that has a positive response to an anti-epileptic medication, as long as they're tolerating it, I would just recommend keeping them on it, even if they've been seizure-free for a year or 2 years. Usually about the 2-year mark, especially with a young animal, I start talking with owners about, should we try to taper? But the risk there, is relapse, and it's significant. Here's another great review for your later enjoyment. This one is by Heidi Barnes-Heller. It's on feline epilepsy, and it was featured in the 2018 Vet Clin. So just wrapping up to review, Assess your patient in a quiet room. Do your hands-off exam first, and then prioritize your hands-on components according to what you learned from the hands-off exam. Posture is key, and don't forget about the tail. FIP and CNS neoplasia are common causes of CNS disease in cats and should probably always be on your list of rule outs when you have a cat patient presenting to you with clinical signs localizable to the CNS. And then finally, just because you have a patient with seizures doesn't mean it's suffering from a sinister intracranial pathology, because idiopathic epilepsy in cats is also possible. So that brings us to, first, I just want to thank my team, the neurology service at NVS. I love you guys, and I look forward to coming to work each day because of you. This was our Christmas picture this year with our ugly sweaters. And I wanted to thank everyone again for Zooming in, and just say that I really look forward to meeting more of you in person one day when we're all allowed to socialize again. Also, my references are available on request. This picture of me doing a spinal tap on a clouded leopard is here to distract you from asking for my references. But no, just kidding. Becky will have them in notes versions with my slides for anyone who wants them. And again, I just really thank everyone for showing up tonight. This was my first CE with NVS, and I was pretty excited and nervous about it. So it made me feel great to have such a good outcome.